Hi, so a very good morning. So today we are going to discuss torticollis, that is also called as wry neck. So we will learn first the theoretical part and then we will discuss it with the help of a case presentation. So if we talk about causes of torticollis in infants and children, so the most common cause is what we call as congenital torticollis, that is sternocleidomastoid tumor, which commonly appears at 3 weeks of age. That is, you have to remember. Then the second is abnormal position in utero can be a cause. It will improve with age. Then the third is cervical hemivertebrae. So this is what one can feel on clinical examination. So it is structural, confirmed on structural and confirmed on plain radiograph. Then cervical lymphadenitis और abscess के form में हो सकता है. It will be usually acute condition and occur in the first 2 years of life. Then retropharyngeal abscess and pyogenic cervical spondylitis हो सकते हैं, where it is also acute and sign of toxicity will be there along with cervical pain and can also be present as a symptom of ALL. Then posterior fossa tumors. So posterior fossa tumor के cases में it will be there, but it will be a rare cause, and the associated headache and vomiting will be there along with other neurological sign. Then one thing is because of the Roche position in the tonsillectomy, there can be acute atlantoaxial subluxation, so that can occur. Then atlantoaxial rotatory subluxation, it is usually seen on dynamic CT and spasmodic with Sandifer syndrome. So this is due to GER. Okay. Then congenital absence of sternocleidomastoid muscle, which is very, say it's a unilateral and extremely rare cause. And postural torticollis is usually familial. As I already discussed, the most common cause, it is the tightening and shortening of sternocleidomastoid, which is seen in around 0.4% of the all newborns, and usually seen on the right side, that is 60%, and bilaterally it is on 2 to 8%, and persist for 1 year. Older children usually the muscle will undergo fibrosis and it will be shortened due to previously unrecognized sternocleidomastoid tumor. If we go in the history, the term SCM tumor was first used by Husinger in 1826. First sternocleidomastoid division was done by Menes in 1641. And the interesting part of history that people say that Alexander also had some form of torticollis. So if we go on etiology, congenital torticollis is rarely noticeable at birth, as we have already discussed, and then there are several theories to discuss it. The idiopathic intrauterine embryopathy and intrauterine positional disorder causing SCM compartment syndrome, then the breech presentation, assisted delivery. So antenatal detection is not recorded in literature as till now. And there could be a concomitant hip dysplasia that you have to see while taking the history of these kind of children. So if we go on pathology, there will be a fibrous replacement of muscle bundles on histopathology. It will also called as fibromatosis coli and classified with Dupuytren contracture and plantar fibromatosis. Histopathologically, there will be endomysial fibrosis and the deposition of collagen and fibroblast around the individual muscle fibers that undergo atrophy. And the sarcoplasmic nuclei will appear as giant nuclei because of multinucleated formation. So there is a concern whether it begins before birth, because there is due to the maturity of fibrous tissue, and there is associated contribution to obstructive difficulty during delivery, which was thought other way around in the previous literature. So there is associated breech delivery 20 to 30%, and 60% are associated with complicated birth because the fibrosis may affect the position of the fetus in utero and perhaps even prevent normal engagement of the head in the maternal pelvis. So natural history of complete resolution is seen in around 50 to 70% by 6 months, and 10% of the tumor and the SCM shortening persist beyond 12 months of age. So on the basis of severity and distribution of fibrosis within the sternocleidomastoid, when we examine the anterior border of the sternocleidomastoid muscle, whether it is present throughout the length or there are some areas where this fibrosis or the area of thickening is present. So there is one classification that is from the American body, and which was revised in 2018, and there are 8 grades of torticollis, which they have like divided into early, late, and very late. So early was further classified into mild, moderate, and severe, and late was further classified into mild, moderate, severe, and extreme. And then the last one is the grade 8, which is very late, when infants and children who are more than 12 months of age with any asymmetry, including postural preference, any difference between the sides in passive cervical rotation or a sternocleidomastoid mass. So if we talk about clinical feature, there will be a hard spindle-shaped painless discrete swelling, usually 1 to 3 centimeter in diameter, in the substance of one of the sternocleidomastoid muscle, and it will become evident around 3 weeks after birth. Obvious head tilt and torticollis tends to develop later, and infants, they will usually rotate head to the opposite side of the tumor with only slight flexion of head to the affected side. You can see the image here. So sternocleidomastoid is less discrete, and it appears to be thickened and tightened along its entire length, and shortening will restrict the rotation and lateral flexion of the head, and one can measure the rotational component of the sternocleidomastoid that we can see here. If there is a sternocleidomastoid restriction or the right torticollis, then we have done the neutral, and then the limited range of motion is there. So the elder children will do a shoulder elevation to keep eyes at a level, at a similar level, and the shoulder elevation will be of the affected side. So here you can see there is the left torticollis and shoulder elevation of the same side, you can see. So this is not seen in infants because they, until they are not gain the ability to stand up or to sit, they do not need it. So moreover, older children do not turn their heads to contralateral side as much because they tend to compensate by twisting the neck and back to keep their eyes pointing forward. So we have already discussed differential diagnosis and causes, but still we will learn one by one. So whether it is occurring because of the shortness of one sternocleidomastoid or by some other condition. So sternocleidomastoid fibrosis will be there. There is no role of plain radiography whenever one can clinically examine it. USG will tell you whether there is a chances of spontaneous resolution or not. It is not needed for diagnosis. And sometimes the radiologists who are not experienced enough, they can further say to do a further higher imaging, or can also recommend biopsy, which is not required, especially in case of typical palpable mass where the torticollis is already identified. MRI and CT can also help in diagnosis, but it will not alter management. Okay. And there is something called as ocular torticollis, which is occur due to squint. So squint will lead to head tilt, imbalance in the rotation of eye, so which can or cannot be associated with sternocleidomastoid fibrosis. So eye muscle imbalance will lead to abnormal eye position, compensatory head posture, and eye will become better aligned. So there will be a ocular torticollis along with muscular torticollis. So it can present with it and it cannot present with it. Then posterior fossa tumor, we have already discussed. It will compress the brain stem at the foramen magnum and will cause acute neck stiffness at one side, and can appear as a first sign, the first manifestation of these tumors along with the other clinical signs. So careful neuroexamination will reveal abnormality in the lower cranial nerves and cerebral functions. Hemivertebra, we have already discussed. It will be a non-progressive torticollis, and inspection and palpation of the dorsal cervical spine can help. So thank you for the part 1. I'll do the part 2 and 3 very soon. Thank you so much for patiently